On behalf of the Skin of Color Society and HCPLive, thank you for coming along with us in our first year of the Skin of Color Savvy podcast. Today, we present a reel of highlights from 2025. We hope you enjoy.
When you look at certain diseases, there are certain diseases that are heavily affecting skin of color patients. So atopic dermatitis, much more common in skin of color patients, particularly African-American patients, as well as prurigo nodularis, where you get those hyperkeratotic nodules on the skin. There are other conditions like lichen planus, CTCL, cutaneous T-cell lymphoma that have unique presentations. But at the top, there's differences broadly with how often are these diseases occurring. And what I think is really fascinating is itch is actually a mirror into society, because you have the epidermis and then you have these nerves, these thinly myelinated A delta fibers and unmyelinated C fibers. And Andrew, they come almost all the way out to the epidermis, the dermis. And so it really reflects many different things. Your environment, for one. So say there's socioeconomic differences and you're in areas that are heavily polluted. Well, that particulate matter, pollution, is actually more likely to trigger this nerve that then autoregulates and creates an inflammatory cycle.
It is really full circle for us to do this podcast episode, because you're right. We did meet through SOCS so many years ago, and we've collaborated on so many fun things together. And we have the pleasure of also getting to overlap clinically with our passions in the pigmentary world. And so whether it's vitiligo or hyperpigmentation or everything in between, we've gotten to really explore that space a lot, both in the clinical and research realm. So I think why don't we just start out with just talking about common pigmentary disorders, because I think people don't realize how many there are. And I often will get this really loaded question, and you probably get this too, which is, how do you like to treat hyperpigmentation? At which point I always have to pause and say, well, let's backtrack and talk about what kind of pigmentation it is. So if you could just maybe talk about the most common pigmentary disorders, and then we can delve a little more into, diagnostic workup.
Yeah, no, that sounds great. And you're right. There's over 45 causes of facial hyperpigmentation alone. So where do you begin? But I guess in my clinical practice, I see a lot of post-inflammatory hyperpigmentation. I see a lot of acquired dermal macular hyperpigmentation, which is the new umbrella term that describes lichen planus pigmentosis, erythema dyschromicum persistens, and Reals melanosis. I also see a lot of nevus of Ota and Hori's nevus, and I think the Hori's because of the population that I treat. Of course, congenital dermal melanocytosis, formerly known as Mongolian spots, is another common one that I see. And we can't go without mentioning melasma, though I'm sure we'll dive into the fact that it's not only seen in skin of color. It's not disproportionately affecting those with skin of color as we once thought. But those are probably the most common ones. Nada, what about yourself? Are you sort of feeling the same in LA?
Yes, 100%. And, I've been in LA, New York, multiple cities. Those are definitely the most common on the disorders of hyperpigmentation. And, maybe I'll just expand on that. When we move along the spectrum to hypo and depigmentation, there's a whole plethora of disorders we see there, right? Some of which are common everyday things like seborrheic dermatitis, less common ones like progressive macular hypomelanosis, seborrheic macular hypopigmentation, which we're still trying to understand, right? And then all our disorders of depigmentation, vitiligo, which is near and dear to us, and then many other causes of depigmentation, things like chemical leukoderma or, late-stage infectious diseases like onchocerciasis or pinta, things we don't see every day, but which also can cause depigmentation. So I think one take-home we really want people to remember is just how broad and how diverse pigmentary disorders are, right? And that within each of those spectrums of hyper, hypo, and depigmentation, there's a whole differential to think about.
How much detail do you go into with these patients about hairstyling? How do you manage that with the time constraints?
Yeah, I remind patients that we have a long-term relationship. We're not going to answer all their questions. We're not even going to get to all of their concerns maybe in the first visit or even, the next visit, depending on how many concerns they have. A lot of patients will just, oh, by the way, my hair is falling out after we've already done the full visit and we've spent a lot of time. So I just remind patients, one, this may take multiple visits. And we really do. It's very time consuming for me. I'm training residents. And so we really get in there. We ask a very thorough history. We're asking everything. And when the residents come out, then I'm asking even more questions, even things that they may have left out. We ask about, their medical history. We ask about whether or not they've been under any stress. We ask about their hair care practices in particular. I want to know, what type of styling are you doing? And so we really do get into the nitty gritty, and it's definitely not just like a quick visit. We may need to schedule a few visits to make sure that we get through everything. I do try to talk to patients as much as possible, especially if I feel like we're going to need to do a biopsy. So that way we can at least get that done and have a really, thorough history and really try to get to what exactly is going on.
So I absolutely love what you're saying. I have learned the same. A few things. One is I will only do hair loss. So at this point, about 90% of my patient care is hair loss. I'll see 30 hair loss patients in a day, which is not a small feat, right?
Right.
And you cannot, oh, by the way, right, with toenail fungus or
No.
on your pinky toe, right? The hair loss takes more than a full visit, right? We schedule it 15-minute increments.
Yeah.
So I don't even do a biopsy the same day as the initial visit. I find that getting a really good history and having a conversation about what I'm seeing and what I'm thinking takes a visit. I also find that most patients don't come in thinking a biopsy is even in the realm of possibility, and they've got to get their mind together for that. So I spend a lot of time prepping them for it and telling them, listen, when you wake up on biopsy morning, you're not going to want to come, but you bring yourself in here anyway, because we are going to do what we need to help you. And then we have a follow-up conversation now based on time constraints, usually by phone, to then I prep them for the treatment plan. But if, there's a biopsy, we're going to talk about the treatment after I get the results. So we spread it out. These are long-term relationships.
What are the things that make you optimistic about the future as it pertains to diversity in research and diversity in clinical trials in general?
Probably the super relevant to this talk is the impact of the Skin of Color Society. So I've been going to the Skin of Color Society since I before I won one of their first awards, and I was young at that time, maybe 17 years ago, and it was a much smaller venue, a much shorter meeting, and many fewer speakers. So the transformation that's happened, the interest in Skin of Color as a society it's just grown so much, and now I have so many colleagues, and I get to expand that friend circle by so much because there's just really so much engagement, and that's going to translate into diverse questions and diverse research and outcomes and better for patients. It's a great privilege to be a part of that.
Yeah, I was going to say the same. I think just watching Skin of Color Society grow, the number of funding mechanisms, the different, researchers every year that are awarded, and you're just seeing the impact grow and grow because so many of our diseases, as you mentioned, vitiligo, my disease of interest, CCCA, I mean, 20 years ago, what was known about these diseases, right? These are both diseases that disproportionately impact people with pigmented skin types. And for that reason, there wasn't a lot known about it. And then you look today and you're like, oh my gosh, wow, so much work is being done. And I think that Skin of Color Society has really been at the forefront of so much of that, right? If the work you're doing in vitiligo has been transformational, and one of your first, supporters was Skin of Color Society, and the same for me. And so just seeing, I think, the organization grow has truly been so inspiring.
I was diagnosed when I was in ninth grade, but I developed HS when I was 13, so around sixth grade. And around that time, I had healthcare. So I had access to a healthcare professional who could see me and look at my symptoms, but I was bounced around to so many different people, and I was told everything from I had a rare blood disorder and I was going to die to having MRSA. So I was on this roller coaster of a ride before I got diagnosed, really trying to understand what was happening to my body, and I couldn't wrap my head around it. I had at that time always been chronically ill, so there was always something going on, but HS was different because it affected my skin and it debilitated me very often. So I started out with I would say about a golf ball size lump under my right armpit. And that turned into most of my body in your typical areas being affected with HS. So under the breasts, the groin, the armpits, the buttocks, the thighs, the torso, my back, those different areas were affected, and it impacted everything in my life because it took over my experience.
I like the point you made about long term, and I think that there's a couple of bits I want to highlight from some of these topical options that really meet the needs of what our patients are looking for, especially when you think about the amount of damage long-term topical steroids can do for patients that have darker toned skin when it comes to dyspigmentation, atrophy, and changes in that regard. Yeah. And we'll start with tapinarof because I think that's a great place to think about the fact that in the clinical trials, number one of the most diverse trial sets we've seen actually from the pivotal phase 3 trials in terms of inclusion of patients of non-white race. And so that's actually quite remarkable, and it's kind of been a guide point for how we can actually have a really diverse population in clinical trials. The other point is the design of this study, one that really tried to mirror what might happen in real world when patients get totally clear and do a really good job. As it turns out, for individuals that are managed to get their disease under control and they just kind of generally stop using therapy, they can actually go a really long time. We're talking on the order of months before they really have to restart therapy if their disease becomes mild enough.
We have like a sheet we give folks on sun safety where we have various different brands that are very popular, whether it's Neutrogena or, Supergoop or Banana Boat or, all of those different kind of, they don't pay me, by the way, but those are examples of different products. I don't know if there are certain ones that you find, that are good.
I'm with you, Dr. Adamson. I try not to recommend either because I just want them to use something that they are going to feel comfortable applying every day. So what I might do is say something like, okay, do you want like a glossy, refreshed look? Do you want more of a matte look? And I'll kind of tell them, there are, and the same thing, we have a sheet and we provide them with a sheet with all these different kind of sunscreens. And I say, you'll find that this one has more of a milky liquid solution. This one has more of a matte finish. So it depends on what they want. I also think the price point is really important, right? Because we talked about investing, that can be expensive. I don't know why sunscreens are so expensive, but they really are, especially the more kind of cosmetically aesthetic. It's like, oh my gosh, it's like you have to like, and so I tell them, I was like, look, really, if you're going to invest in good sunscreen, use it in the areas where maybe you don't really want to get worsening of that hyperpigmentation. So on the face, and maybe get something a little bit less costly to use on the rest of your body, But I do think that trying to be creative and help them reach goal is something that I try to spend some time with. But I think it depends on the cost, on their needs. And I'm with you. I'm like, I really don't care as long as it meets the UVA. If it has the tinted sunscreen, that's a plus. And if you're using enough of it, I'm happy.
I would love if you can explain to us too, some of our readers, our subscribers may know about ILDS, which is the International League of Dermatology Societies. How is Glowderm connected with ILDS?
Yeah, absolutely. So I'll take that just because I also serve currently as the vice chair of the International Foundation for Dermatology, which sits under the ILDS. So we talk about it in global health. There's a lot of kind of alphabet soup. So let me try to break it down for you, and because it can be really confusing. We all have the word global or international in our title. So the International League of Derm Societies, also known as ILDS, you may be familiar with it because we put on the World Congress of Dermatology that happens every 4 years. It was in 2023 in Singapore, and it will be in 2027 in Guadalajara. Guadalajara, Mexico. The ILDS is this meta society of societies. So what it is the American Academy of Dermatology is a member, Skin of Color Society is a member, the Chinese Derm Society is a member, the Australasian College is a member. So it's basically not an individual membership society. It is a society of societies. So ILDS has, we're very lucky that we are, because of funding through the World Congress of Dermatology and other things, we're able to have a foundation arm, which is called the International Foundation for Dermatology. So we are kind of the foundation and humanitarian arm of the ILDS, and I'm the vice chair of that, and the chair of that is Claire Fuller. And then we're very lucky at Glowderm that we then sit within the International Foundation for Dermatology, which is the kind of foundation arm of the ILDS. So that's a lot of acronyms, but we're, I think, really lucky to sit within that organization just because it provides such an incredible resource and kind of connections to the presidents of the derm societies around the world.
That's incredibly helpful. Thank you for explaining that, because I think many people, like you said, have heard that alphabet soup and they just don't know where everything lives in the big picture. So thank you for explaining that. One of the things that I always find frustrating as a dermatologist is when a lot of our conditions are seen as more cosmetic, and we really, kind of get undermined sometimes in the house of medicine with the importance of the work we do and the diseases we treat.
What are the pitfalls that you've noticed when you're diagnosing vitiligo? Like, where can people get it right? Where can people get it wrong?
Yeah. And I think that the thing to remember with vitiligo, it's such a individualized disease where everyone has their own unique perspective. You can have a patient coming in with very extensive involvement who doesn't want treatment and feels like this is just part of my identity. I don't need treatment. And then on the flip side, you have someone with just a tiny, small little patch on their skin, and they're so distressed by it. So I think it's really important to, one, of course, we want to assess a person's degree of vitiligo, look for those signs of disease activity and rapidly progressing vitiligo, or, signs that, patients are going to have more recalcitrant disease, like, that acral fingertip involvement. But I think we also have to see the impact on the patient's quality of life in terms of, deciding how aggressive we need to be in treatment. And I think the one thing that really, really bothers me when patients come in, because of course we're at a tertiary care center, a lot of times our vitiligo patients have come through a couple providers. And sometimes they tell me, doc, I didn't get treatment for this for many years because I was told this was a cosmetic condition. And that made me feel bad that, like, why am I getting treatment for this if it's, if it's not even real? And then other people told me that there weren't any treatments for this. And so I think, just having the awareness of the fact that vitiligo is not a cosmetic disease, there are treatments that are available and that are being investigated to manage vitiligo. I think that's the main thing. And if you don't feel comfortable treating vitiligo, I think it's very valid to kind of refer that patient to someone who does feel comfortable. But I think that initial, discussion with patients to see where they're at with their vitiligo, how they want to manage their vitiligo, and then giving them that hope that there are things that can.
Why should a dermatologist care about curly hair? So I know my answer, but I just want to get a sense of your thoughts. Like, why should we even be talking about this?
Ooh, that is a loaded question. I feel like I could give a million reasons, and probably so could you. I think at the meat of that question, though, it just reminds me of the patient interactions that I have on a daily basis. Hair and identity, especially curly hair, is just woven into who our patients are. And when you think about, how the impact that something like taking care of curly hair, the challenges, the financial impact, societally, thinking about professionally, curly hair matters. It's can be challenging at times. It can be particularly challenging when you're facing hair loss disorders. And truthfully, I find that many physicians are becoming more comfortable having conversations that talk about things like styling and the intimacy of an identity, but they're not natural conversations for everyone who doesn't have curly hair, which is understandable, right? So I think it matters because we need to feel more comfortable and empowered to, give the right information to our patients, because this matters for who they are as individuals.
Yeah, absolutely. I mean, one thing that I try to tell dermatologists, Curly hair is prone to breakage, it's fragile, it's dry, and it is at increased risk for medical disease, right? Just like dry skin. So if you are a dermatologist and someone told you, oh, you don't have to know anything about lotions. If it's not a prescription, you don't need to know, or you don't have to know anything about sunscreens. I think 99% of dermatologists would be like, no, I absolutely have to understand how my patients take care of their skin on a daily basis outside of my practice, because if they don't, it leads to skin disease. And
and it's so important, I think, to get this message out to men, because I think men think also that they just have male pattern hair loss. And so, they don't necessarily realize that when we're giving them this topical medicine or oil medicine, that they really have to consistently take it. I think that's true for women, of course, too. But for men particularly, they just want the stuff that they can get online, and they're fine with that, but they're really not fine. So I agree with you. I think it's so important to tell them, there's two things going on here. There's the white blood cells attacking your hair follicle, and then there's also this growth issue, and we can deal with the growth issue, but we got to get the white blood cells down, or else you won't have any hairs to grow.
Exactly.
Yeah. So how do you go ahead?
I was going to say, I feel like that's a huge part of the visit too, is explaining what that means, because most of them are coming in expecting the first two medications that we talked about, minoxidil and finasteride. This is what they're coming in for often. So we really usually have to do a lot of teaching to tell them, why exactly they're on anti-inflammatory treatment and what the outcome would be if they don't follow through.
Something that we don't think about. We think about winter skin and the wind blowing and like windburn and the dry skin from being outside. But it sounds like, and from my experience too, from the little period of time that I lived in a cold climate, that winter skin also has a lot to do with indoor dryness. It's a big problem. So do you have any clinical pearls? Like, what do you tell your patients? What do you think about when, and I'm sure you've come up with many more since you've moved there, because for the first 4 years of your career, you didn't really have to think about this so much.
Yeah, so absolutely. There were some things I had to, kind of think about a little bit more, do a little bit of research. Even my own personal self, I invested in a humidifier. So humidifier, game changer, because again, when you're in your apartments and, all these spaces that the dry heat, a humidifier has really been a game changer. So this is an easy way, it doesn't have to be anything crazy expensive. You can go, buy like a cheap one. And this is something that can add moisture into, your air while you're sleeping. And this can really help with, really winter dry skin. Other key things are making sure that, you got to moisturize your body with a heavy cream, not some lotions. We got to use creams because these are much thicker. So a lot of times patients really, maybe don't know the difference, but lotions are more water-based. And it's better to use like really thick creams. And the best time to moisturize your body is as soon as you come out of the shower. Now the shower, even though it might be really chilly outside, we want to make sure that we're not doing too hot of showers, even though that might feel good. We want to, ideally be using kind of lukewarm water. And that's because using hot temperature water, that's going to dry your skin out even more. So you want to keep the showers quick, lukewarm, and then as soon as you get out, don't even towel yourself off. You should put the thick cream moisturizer all over your entire body, head to toe. And even better is then to take some petrolatum, like, petroleum jelly, and put that on top, because that helps to really seal the moisture into your skin.
Thank you again for joining us in 2025. Check out the podcast in 2026 for a new year of great conversations.